you introduce the panelists. Okay.
Sure, sure,
Then you start the program, right? So
sure,
that will
sure.
be the flow. Sharik, please go live.
You are live now, sir.
Good evening, all. So, welcome to another episode of Contact Lens Learning course. As I have said several times, contact lens is something that we all want to do, but we hesitate most of the time because we don't have access or we don't know how to use it. So today there is a very important topic and we have two great speakers, Dr. Arthur and Dr. Chris, and we have a very good panelist with us. And the moderator for today is Dr. Ritika Malik. She will introduce our speakers and then she is going to introduce our panelists and then we'll proceed with our lecture series today. Thank you so much, all the audience who have joined. And Ritika, you please introduce our
Sure.
speakers.
Okay, good evening, everybody. So, my name is Dr. Ritika Malik. I'm currently working as a cornea and refractive consultant at iCare Noida. And it's my privilege to introduce our esteemed panelists and our very academically achieved speakers also. So, first, I'll introduce Dr. Krish. He's a diploma in optometry and he's qualified as an optometrist from the Technikon in Johannesburg University in 1985. In 1992, he passed the British College exams and registered with the General Optical Council. In the 1994 year, he registered with the Opticians Board in New Zealand, and in 1999 with the Board of Optometrical Registration in New South Wales. In 1987, he was elected chairman of the Western Cape branch of the South African Optometric Society Association and served in that position for many years. Dr. Chris has served as a director of the SAOA for the 10 years, holding various senior positions in the organization. Dr. Chris was elected to the position of Public Health Director for the SAOA from 2003 to 2004 and to the position of Vice President of the SAOA from 2004 to 2005. He was elected President of the SAOA from 2005 to 2006. And from 2006 to 2008, Dr. Chris was the ambassador and financial director for South African Optometric Association. He was also the chairman of the Bonang Eye Care Centers until 2008. Welcome, Dr. Chris.
Thank you.
Next, I would like to introduce Dr. Arthur Tong. And Dr. Arthur is a board certified ophthalmologist practicing in Taiwan. And he chose to specialize in contact lens and treatment of binocular vision function problems in children. He is the inventor and worldwide patent holder of lenses for variety range of orthokeratology, specialty contact lenses, and corneal rehabilitation for altered corneas. So he currently holds 9 US patents, 5 Chinese patents, and 2 Taiwanese patents, and more worldwide patents in the design of ortho K lenses and specialty soft contact lenses, of which the most well-known designs are high myopic molding, dual geometric hyperopic, and presbyopic ortho K and ortho K simulation soft lenses for myopia retention. So his education is from 1976 to 1983 for Bachelor's of Medicine degree received from the Kaohsiung Medical College in Taiwan, and he was awarded his degree in 1983. Welcome, Dr. Arthur. So next I would like to introduce our esteemed panel. So Dr. Charuta J. Puranik is the founder and director of Oculus Regenus Biotech Private Limited and senior cornea and ocular surface consultant at Medivision Eye Hospital, Hyderabad. She is a clinician scientist deeply committed to translational research. She integrates clinical excellence with innovation in regenerative ophthalmology. Her work has been recognized nationally and internationally, including the Barack DBT Biotechnology Ignition Grant for Translational Innovation and the Champion Mod Award for Research for her contributions to corneal transplantation and vision restoration. Ma'am's special interests lie in ocular surface disease, dry eye, and immune-mediated corneal and conjunctival disorders, where she bridges the gap between ophthalmology and systemic immunology. Through her research and clinical practice, she continues to explore the intricate interface between autoimmunity, inflammation, and ocular surface regeneration, inspiring collaborative models between ophthalmologists and rheumatologists. I welcome Dr. Charuta ma'am. Next, I would like to introduce Dr. Meena Lakshmipathy ma'am, and she completed her MBBS from Stanley Medical College in 1997. Completed her MS Ophthalmology from Government Rajaji Hospital in Madurai in the year 2001, and went on to do her long-term fellowship in cornea and anterior segment at LV Prasad Eye Hospital, Car Campus in Hyderabad in the year 2004. Ma'am has worked as a cornea consultant in GMRV LV Prasad Hospital, Visakhapatnam up to 2010, and is currently associated with Shankara Nethralaya in Chennai since November 2010. She is the chairperson for the Hospital Infection Committee at Shankar Nethralaya. Her key interests are microbial keratitis, pediatric cornea, lamellar cornea, and refractive surgery. She is a well-known speaker at several forums and has taken part in many instruction courses and paper presentations internationally also. Ma'am was awarded for her research in cornea by Women Ophthalmology Society in Women of Ophthalmology in 2021 and received the Best Women Scientist in Infection Keratitis award in 2019. Welcome, Dr. Meena ma'am. Finally, I would like to introduce Dr. Ashi Khurana ma'am. And Dr. Ashi Khurana was the founder director of CL Gupta Eye Bank in 2003. She laid the foundation of modern eye banking in Moradabad. Since 2012, she is the vice chairman of the most modern eye care facility of Western Uttar Pradesh, which is known as the CL Gupta Eye Institute. She has made various scientific presentations at local, national, and international forum and has also been invited faculty in many various scientific conferences. She is actively involved as a partner member of Vision 2020, Right to Sight India, and Sight Life International USA, Orbis International, and Operation Eyesight Universal. She is also associated with All India Ophthalmological Society and Women Ophthalmological Society of India. She has trained many ophthalmic surgeons in her subspecialty, which is cornea, and is actively involved in refractive surgery, lamellar corneal surgery, microemulsification, and ocular surface diseases. She has been actively involved in the drive to improve the quality of services and systems to deliver eye care. Welcome, Ashima. So I would like to request the speakers to now please start with the talk.
Is that clear?
Yes, the
Yes,
slides
sir.
are visible. You can move. Yeah.
Yeah. Thank you very much for inviting Dr. Tung and I to share some information on orthokeratology, myopia management, and the use of RGP lenses and soft OK lenses. So we are often joined by Dr. Johanna Tung, who's not with us this evening, but she's one of the lecturers in our team. And thank you very much for that really great introduction of both of us. The next 5 hours, we'll talk about GOV calculators, basic trial fitting, how to order GOV lenses online, and how to consult with the online forum. So I definitely won't be here for 5 hours. We'll try and do this as succinctly as possible. I'd like to thank Vikash from V-Square for assisting in this presentation. So we have different ways of fitting these lenses, and so in the next 3 or 4 slides, literally there's two ways. We can do it what we believe is the best way, and that is to do it by trial fitting. But for people that don't have a trial set, you can do it by empirically fitting the lenses as well. So to fit the lenses empirically, we need the K mean. So the mean K, which we all know how to take. It's the horizontal and vertical keratometry or topography measurements, and divided that by 2. We would also need an accurate refraction, because with lenses, we need to tie up the refraction to the power of the lens that we use. We would need either keratometry or keratometry. Corneal topography has become the gold standard because we can see exactly what the changes of the cornea are. With the keratometry, we can only take, as we know, 4 measurements on the cornea, and it doesn't tell us very much. So today, with orthokeratology, and I guess with all contact lens fitting, corneal topography would be the gold standard. It's important to determine the HVID, and there are 2 ways one can do that. One, we could use the corneal topographer and go from the grayscale to grayscale. Different topographers will give us very different readings. So Dr. Tung has actually devised this HVID ruler. And if we can look at 11.2, if we bisect the pupil and go limbus to limbus, that will give us a very accurate HVID measurement. So if we're going to measure empirically, we will go to a calculator that's one can download from the GOV website, and you'll just add in the data. So you'll add in K-mean, the refraction, HVID. If we do not put an HVID in, it will automatically go to a default size, which I will discuss a bit later. There's also an advanced calculator, and this is for things where we have higher astigmatism, where we've got a probably decentered cornea that's a little bit irregular. So we call that a tilted cornea. So if we're going to deal with that, we've got an advanced calculator which can be used, and it asks for different measurements. So different zones, the tilt and the elevation, and we will discuss this in the 3rd talk, where we talk about advanced lenses and tilted corneas and astigmatism. There's also an online forum on the GOV website that you can download, and it's very useful to discuss any problems that one might arise as you fit in the lenses. So this is the website, and it's just www.global-ok.com, and you can sign in, and all the information that we're going to be talking about over the next 4 lectures will be on the website. We will have the fitting criteria, and the forum is there for us to discuss where you have a problem. So once you have logged in, you'll go to the forum, you'll post a new case, you will use all the necessary information, the customer profile, the initial fit information. We prefer to have a small video because it's easier to detect a problem than with a photograph, and you upload all of this, and there will be, so somewhere you'll upload the photograph or the video, wait some time for it to complete uploading, and it will create a case. And there's a panel of us that will then look at it and reply. So that's in case you don't have a trial set and you decide that it's going to be okay to fit empirically. We don't recommend you fit empirically because if something goes wrong, you have no way of checking how to correct it. So it is definitely recommended that we use a trial fitting to prevent any trouble down the line. So GOV has got the most comprehensive lens inventory to correct a wide range of refractive errors. Historically, orthokeratology was only for myopia and myopia up to -3. Dr. Tung has done some great research into the cornea and how to improve that so that we can go everywhere from -1 all the way to -10. And there has been 1 or 2 cases which has been higher than that. He's with a very different fluorescein pattern, which we will discuss in the advanced section of this series of lectures. We can do hyperopia from +0 to 5 to about +6. We've got the thing called dual axis and tilt. So dual axis for regular astigmatism and a tilted lens for irregular or quadrant specific. We can correct post-LASIK ectasias with an EC or CZ lens. And then we can fit hyperopic presbyopic patients with either a hyperopic center near or center distance lens or a myopic presbyopic correction with a center near or center distance molding on the cornea. So it's a really comprehensive wide range of refractive errors that can be corrected with our range of lenses. So it's important to understand RGP lenses when we are fitting ortho-K lenses because there are some similarities. So this is a basic structure of an RGP lens that will help us understand ortho-K. The center of the lens is the base curve with a back optic zone radius. The diameter of this area is called the back optic zone diameter, and this is where the power of the lens really resides. Then there are other parameters such as axial edge lift, the overall lens diameter, the tear layer thickness, the peripheral curves, and the axial edge lift. All of these parameters plays a very important part in how the lens to cornea relationship continues and in comfort and in vision. So we also have what we call a SAM-FAP rule. And this is the tear lens effect on the eye. So if we have So in this schematic representation, it is obvious to see that in the center of the lens, there is a very bright area, or what we call pooling. This indicates that there's a great deal of distance between the back surface of the contact lens and the front surface of the cornea. A lens like this in a regular RGP would have a number of complications where we would have distorted vision or feeling of tight burning sensations, and that's an entire lecture on its own. But this would be what we would call a steep fit. So if you find that that is acceptable, to compensate for a positive tear layer, a minus power needs to be added to the RGP lens to compensate for the thickness in the center. So for every 0.05 millimeter of base curve radius change then on K, we have to add -0.25 power to the RGP lens to keep the same refractive power and the same vision. And the reverse is true with a flat lens. So in this representation, we can see that the base curve or the center part of the lens is too flat and it's resting on the cornea so that the edge is lifted off the cornea. This is a condition that the lens might decenter easily or the lid might flip it out on blinking. There will also be a negative tear layer induced in the center with a flatter base curve. And so to compensate for that negative tear layer, a positive power needs to be added to the RGP lens. And the rule of thumb there again for every 0.05 millimeter base curve radius change flatter than on K, a plus 0.25 power needs to be added to the RGP lens to keep the same refractive power. I'm going to talk a little bit about the basics of orthokeratology. That's just regular RGP lenses, and to understand the concept of how a lens sits on the eye. So in initial modern ortho-K lenses has 4 zones, with peripheral zones that are steeper than the central optic zone, and this is called a double reverse geometry lens. The typical fluorescein pattern would be a bullseye, as we can see in the image on the right. So the central area where we see central push is where the lens is not resting directly onto the cornea, because there's a very fine layer of fluorescein in between. But that area we've called a bullseye. That's flat in the middle. There's a tear layer that creates a negative force of tissue to be pulled into it. Then there's the peripheral area, which is a very dark ring around that central bright ring, and that creates a peripheral push. And then we have to have an edge lift. It's really important that we have an edge lift, because that creates some tear interchange and keeps the eye comfortable. So these are the hydraulic forces that is on the actual eye. We can see the central optic zone and the mid-peripheral alignment zone work together to reshape the cornea with dual forces, which is why we call it a dual geometry lens. The lid pressure is used for central molding, and that's the lid pressure goes directly onto the front central corneal surface. This in turn generates a hydraulic massage to push the central corneal tissue out, and the peripheral molding force is exerted in the alignment zone to push peripheral tissue in, and this creates a very important mid-peripheral ring. So we get central flattening, we got mid-peripheral thickening, and then we got flattening from there on. And I will show this in a slide further on. The sagittal depth applied link the corneal contour with the lens shape corneal molding. The corneal sagittal height, or KSD, is defined by the central corneal curvature and its eccentricity. The lens sagittal height is the lens height measuring from the center top to the lowest edge of the cornea. This is usually determined by the corneal central depth plus a certain tear reservoir of about 10 microns. If we look at an OCT of a human cornea, we can see that there is central flattening, there is mid-peripheral thickening, there is thinning out in the area, and that relates directly to the lens on the eye. My screen has frozen. Epithelial in the center. We got the area of thickening, which relates to that tear ring that we saw earlier on. We got, again, an epithelial thinning from the conformation pressure in the mid-periphery. And that relates to that image has disappeared. Okay, let's talk about an XMJ lens. We will come back to the actual molding. An XMJ lens has 5 or more curves. This is a patent design for myopia. Using enhanced design in lower myopia, The XMJ lens will mold the cornea faster, and the effect will remain longer than the traditional lenses that we had before. The aspheric alignment zone enhances the peripheral inward forces and centers the lens a lot better. So this is part of the basic fit. The XMJ lens is good up to -5. Anything over -5, we move into something called an XM lens. So the XM lens is a design used for high myopia, molding up to or even over -10. The unique XM curvatures enhances the peripheral inward pushing force to reshape the mid-peripheral portion of the cornea, where we find a lot of epithelial tissue, to create a much steeper, enhanced central flattening. This will be discussed in the advanced section of the lectures, but generally, a two-step procedure is sometimes needed as we progress in the correction of a high myopic molding. This is what we call the bullseye pattern, which we typically see in myopia molding. And we can see the 4 important areas of the lens, which is the clinical picture that we require when fitting these lenses. There's the areas of touch, which is in the central and the peripheral portion. And there's a very, very thin layer of tears underneath the 2 areas which we regard as bearing on the cornea. So a very, very thin layer of tears underneath it. The 2 zones of no touch is the tear ring and the edge lift. The tear ring is important for the epithelial tissue to be molded into that ring, and the edge, as I said before, is important for tear interchange, keeping the cornea healthy. So to order GOV lenses, we need a couple of things. We need a K code, and which is the mean K. So it's the horizontal and vertical Ks added together divided by 2. E value is optional because it's already been built into the lens, except when we have a very, very high or a very, very low E value, there's a way to actually correct and add it in. We work in quarter diopter steps, and we choose the lens which has got the closest K for the K code. Then we have the power code, or the spherical equivalent. This is derived from the spherical power of the refractive error and the corneal SIL. It's really important that we don't use the refractive SIL, but the corneal SIL. The corneal SIL is used because we are targeting the cornea, and vertex is not required for refraction over ±4, as this has been incorporated into the contact lens already. So the vertex has been done, there's no need to vertex. Before we use the calculator for empirical design, we need the corneal curvature from an autorefractor or topographer, the corneal size, HVID. Subjective refraction, including AD for presbyopic molding, taking corneal topography for E values and elevation data, in case we want to use the advanced calculator. And for trouble prevention, the standard GOV trial set is useful so that we can fine-tune tightness for size control, which we will discuss in the next slides. So if we are using the simple calculator, as I mentioned in the beginning of this talk, the simple Excel calculator is available for you to download from the website www.global-ok.com. This is a basic calculator, and you only need to put in the Ks and the refraction and the HVID. If the HVID is not specified, or you forget to take it, there will be a default diameter depending on the size of the K readings, and that will be assigned automatically. This is not ideal, but it will give you about an 80% success rate should you forget to take an HVID. We strongly recommend that HVIDs are taken, as I will demonstrate in some videos further down. This is the advanced calculator once again, and to design dual quadrant-specific dual design lenses, the GOV offers a very convenient advanced calculator. If you do not apply the e-value and the elevator data, the advanced calculator will be the same as the basic calculator. Important that one applies the e-value and the elevation data in this particular calculator. If the e-value is applied, the calculator will compensate the K-code by e-value for the corneal sagittal height. While the e-value is not always reliable with the topographer, it would be better to trial fit according to the suggested K-code and to then double check. Once the best fit K-code is verified and the K-code can be applied in the gray zone at number 19 to lock down the K-code. The lens size can also be locked down after you've trial fitted and you're happy with the size. The power code can be determined empirically without over-refraction, which is usually fine. The K-code can accept either millimeters or diopters in this calculator. So to fit the GOV system, it's really, really simple. We go through the normal eye exam. We've got to determine the K-code by mean code. We've got to select the power code by spherical diffraction, spherical equivalent using the corneal sill. We can then order the lens empirically or after trial fit. The lens size is determined from an HVID ruler, trial fit, or if not specified, there's a default lens size that will be applied. So to derive the K-code, as I said before, all we do is we take the horizontal and vertical Ks, add them together, and divide them by 2. To get to the spherical equivalent, we would use the myopic component, this the spherical component, plus half of the corneal sill. So in this example, if we took the K-mean, 82 and 87.87 and 44.75, add those two together, divided by 2, we'll get 43.81. The RX of this particular patient is minus 750, minus 150 at axis 180. The spherical refraction would be the minus 750. We then add the K-mean, the vertical and horizontal of Ks, divide that by 2, and we get to a spherical equivalent of minus 8.44. So in this particular example, our selected lens would be, because it's above minus 5, an XM lens, 43.75 K-code, minus 8.50 spherical lens with an 10.8 millimeter standard lens diameter. So why is it important? If we look at the 5 images that we have right here, we can see that we have various K-codes. The center is exactly what we are looking for. We've got a bullseye, we've got a beautiful ring, and we've got a peripheral edge and an edge. If the lens is a little bit too loose, if we look at the top right-hand image, where we're about half a diopter too loose, we can see that the lens is still going to cause some correction, but at the inferior section, there's a bit of bleeding. On the top right-hand side, that lens is about 1 diopter too loose, and we can clearly see that there is no seal off at the bottom of the lens. The top right-hand will still cause a refractive change, but the treatment zone will be smaller than the optimum. So this is really important why we need to have the correct K code. If we look at the images at the bottom, those K codes are either on the bottom left or half a diopter too tight, and we can see that the center is got a lot more pooling. And this similar, you can, if you remember the pictures of the RGP lens, we can see that the center is pooling there. And if it's a diopter too tight, we can clearly see the pooling in the center. This will not create any pain on the cornea. So if we look at a video, we can see that this is a proper fit where we've got a little bit of movement. The lens is centered very well. We've got an edge, we've got an alignment curve, we've got a flat center, and we've got a beautiful tear ring. And that's really what one's looking for as a bullseye pattern. If we look at B, the lens is a little bit too tight by about a diopter, and we can clearly see the pooling in the center. When we get to troubleshooting, this type of fit will give us a picture that we call a central island, where there'll be a slightly raised area in the center, but there'll be all sorts of refractive errors, fluctuating vision, because the lens is not fitting correctly. If the lens is too loose, the bottom left-hand video, we can see that there will be some correction, but the lens is not centered very well. The tears are bleeding through the bottom of the lens. And so you will have a very distorted corneal topography. And the last image, where the lens is very, very flat, we can clearly see that this lens is slipping around everywhere. We will not get a proper molding with the lens like this. Right. Then the HVID, as I said, we need to look at either HVID from the corneal topographer, which is not really all that accurate, or we use the HVID ruler, which will give us a very, very accurate HVID measurement. This ruler you can get from us, or Vikash can probably supply you as well. It is by far the most accurate way of determining the HVID. So after many examinations on eyes, we've worked out default sizes, different KM ranges, and this has taken the general population into account. So if you do not measure an HVID and tell us what it is, this is the default sizes that we will give you. So for K mean from 40 to 42.25, you will get a default measurement of 11.2. That would be the diameter of the lens, which is about 97% of the HVID. If we go to the steeper corneas, 44 to 47, we only cover 93% of the cornea, and the lens diameter will be 10.4. So it's very simple to fit GOV lenses. It is very simple to fit low myopes. All you need is the central K readings, the subjective refraction, and the corneal size, which we'll use from the HVID. So why is HVID so important? The pictures that you see demonstrate how the lens size may influence the pattern. The images that you see here is exactly the same K code, but it's just different lens size on the same cornea. So we can see in the middle where we have 95% of the cornea covered by the lens, we have an optimum bullseye pattern with a nice wide treatment zone, which will give us a good refractive outcome. If we look at the top right-hand lens, where the lens is 89% of covering the cornea, we can see that that lens is much smaller. You will get some correction of your refractive error, but the treatment zone will be a lot smaller. The relief curve, or the tear ring that you see there, is much wider, and the edge is much wider. If we look on the top left-hand side, where we've got only 86% coverage, we can see that that lens is already flat on the cornea. And if we look at the two images at the bottom, where the lens size is larger than optimum for this particular K code, we can see that the lens is tenting up, and it's got far too much fluorescein underneath the lens. So this will demonstrate why the lens size is so important. So these 5 images show us that it's important to have a very accurate HVID. And if we look at the videos, we can see, again, this is the same K code, just different sizes on the same cornea. So A, 10.8 millimeter diameter lens on the cornea. Here we've got a lens that is 0.4 millimeters smaller. And we can see the big difference in fluorescein pattern just by going 0.4 of a millimeter smaller. We can see that that lens also moves around a little bit too much. If we look at the image C, the bottom left-hand corner, where we are 0.8 of a millimeter smaller, you can see how much that lens now moves around. And if we look at D, where the lens is 0.4 millimeters larger, we can see that that lens is a much tighter, and it lifts up off the eye. So just to reiterate, this is the same K code, the same cornea, just different lens diameters. Thank you. I'm going to hand Dr. Pan to do the second part, and then we will take questions.
Okay, is there any question for the GOV fittings?
I think we'll take the questions after your talk, Dr. Arthur.
Sure.
Yeah.
Okay. I cannot see the share. Okay. Okay, here. Can you see the screen? Can you see the
Yes,
screen now?
screen is visible. Yes, please proceed. Yeah.
Good.
Yeah, slides are moving good, sir.
Yeah. Okay, I will back to the first one. Okay, so I will talk about the outermost soft focal lenses. So we create the soft okay lenses with a silicon hydrogel material for daily disposable. And that is a very high decay material with 60% water, and the decay is 80. So regular HEMA lenses is only 20 or 10 decay. So that is 4 or 8 times that of the HEMA lenses, the oxygen permeability. And the pre-made inventory daily disposable soft lenses we can deliver without waiting for production. The range is about -2 to -15 diopters. So, but we are expanding the power downward to planar power for myopia prevention. So now we can cover -2, -15, and that is a quite wide range of myopia that we can treat. Okay, but when we fit the soft lenses, it is important to make sure that we are giving the patient the correct lens. Here you can see that all the fitting requirements are located on the blister pack. The label is quite different from others. That is, there are two codes. One is the M code. That means that there is a M0300MR. So in this lens is indicated for use with the myopia 3 diopters. However, when we check the lens, the power is only -2. So I will explain this later, that the lens actually contains a -1 tier lens that is effective only when putting the lens on the eye. So the lens is effective for -3, and we have to label the measured power for FDA regulation or the so that we have to label it as -2. But actually, we have to tell the user that this lens is actually used for -3. So that is the difference from other lens designs. So here is the material specifications of silicon hydrogel with oxygen permeability of 80 dK. And if counting the thickness, it is 100 dkt for Daywell. So this lens also has a aqua fusion technology, makes the lenses very soft and flexible with many release moisture as needed. So Osocare has been proven effective in myopia control that can slow myopia progression by about 80 to 90%. From the retrospective study of GOV Osocare cases in my clinic, the GOV Osocare system turned out 87% slower in myopia progression statistically. The stronger peripheral inward defocus formed with the GOV Osocare lenses substantially created a progressive multifocal central distant optics. And that is the reason why we can manage the myopia control better than others. Now we can use the soft contact lenses to simulate the GOV Osocare treatment zone with strong progressive inward defocus. We should be able to achieve a similar myopia control effect with the soft contact lenses. Soft-OK design is a unique design for simulation of OSO-K treatment. Here the left map and fluorescent photo is for wearing a soft lenses. So it is not a OSO-K lens, but a soft lens. The fluorescent photo of the soft-OK contact lenses may form a tear ring similar to the rigid OSO-K lenses. That is the rigid OSO-K lenses. So both maps are quite similar, having a smooth and progressive multifocal central zone with strong peripheral inward defocus. We stand the HEMA hydrogel lens with a large molecular fluorescent dye to demonstrate the tear channel here. But please do not use fluorescent when evaluating your patient with the soft-OK lenses. The macromolecular fluorescent dye does not stain the silicone hydrogel material. We created almost soft-OK lens with thickness differences in multiple zones to induce plane fracture of the lens, which turns the front surface into a desired contour. At the same time, the lens also forms a tear space underneath the lens that may correct cornea cylinder without toric design. So the soft lens can correct cornea astigmatism without toric design because we have the tear lens underneath, just like an RGP. The tear space underneath the soft-OK lens may correct significant cornea cylinder without toric design. The optic zone simulates GOV OSO-K treatment and forms a strong progressive multifocal for myopia management. And soft-OK can simulate OSO-K for myopia management. The simulated treatment zone displays excellent progressive multifocals, as here demonstrated a -10 myopia. The optic zone, you can see that even if it is -10, the optic zone can be created as big as 5 millimeter with a progressively steeper treatment zone. So the benefits is one is comfortable for day wear, and there is PVS multifocal, and it also simulates OSO-K treatment zone. With a excellent centration and having bigger optic zone for better far vision. It is also comfortable and astigmatism correction up to 1.5 or 2 diopters. The best is that the correctable power is much wider than OSO-K. And we compare the annual axial length elongation of 8 cases in my clinic with that documented in several published papers for meta-analysis. And we found that soft-OK lens slowed down axial elongation comparative to or even better than atropine treatment or OSO-K. So the soft-OK is an excellent alternative for myopia management in dyskiasis or trichiasis when the patient does not want to receive corrective surgery. The daytime soft lens will protect the cornea from ablation while offering myopia management. So fitting soft-OK lens is simple, but also needs some special skills. Determine accurate K code is easy. In general, it is different from RGP lenses. The K code is only slightly associated with mean K in soft lens fitting. So only 44 K code is available in daily disposable soft OK lens. And doctors do not need to indicate K code in order. Then the next step is to find power code. The power code or P code can be calculated empirically from patient's spectacle refraction. Please note that vertex distance needs to be considered and applied to adjust the calculation. So it is different from the Ortho-K lens. We do not vertex it in our system. We need it to be calculated with the doctor. So the soft-OK lens has partial GP character and can neutralize corneal astigmatism up to 2 or 3 diopters without toric design. So there is also plus or minus tear lens effect for each diopter K reading, steeper or flatter than 44. The tear lens effect versus K reading is about 0.16 diopter per 1 diopter difference from the 44 K code of the lens. So in general, the tear lens effect on eye is about -1 diopter, so that the P code starting with the capital M is always -1 D, higher than the numerical lens power. So here illustrated is the empirical power calculation for a spectacle refraction result of -9.5 myopia and -1.5 astigmatism, with spherical equivalent of -10.25. The mean K is 2 diopters flatter than 44 K code of the lens and need to compensate -1/4 in power code for -1057 before vertex. Then we vertex it for a power code of M0975. And because we have only every 0.5 diopter, so we order -10. So that is a very complicated calculation. So we offer a convenient calculator to help empirical calculation of the P code. It is very easy to just enter the spectacle refraction and K reading to get the power code. Okay, let's see the calculation. The spherical power is -950, and the cylinder is -150, and the K is 41/20 and 42/75. And I will demonstrate a same power refraction, but different K. You can see that the results are slightly different. You can see that one is 1050 and another is 10. So that is because of the K difference. So the power code can also be obtained more precisely by over-refract the appropriate trial lens with vertex distance adjustment. The lens is better inserted with a drop of saline or soft multipurpose solution in the bowl and insert vertically upward, like inserting scleral lenses to prevent from air trapping. We never use stick tear nor RGB conditioning solution, which may wrinkle the lens and hard to expel. So trial fitting and over-refraction for power coat is absolutely required in fitting post-refractive surgery such as post-RK or post-LASIK, and the irregular corneas such as post-cornea transplantation or keratoconus, because the tear lens will be different from the normal corneas. So because we have a tear lens underneath, the lens can be used to fit the post-LASIK or small cones that were smoothen out the corneas and to correct the residual power. So it is suggested that you start to over-refract your patients after applying the trial lenses for 5 to 10 minutes to allow the lens to settle. Okay, trial fitting is highly recommended. The lens has to center very well with little movement for stable vision with the PVS progressive multifocal design. We usually prefer 1 to 2 millimeter movement in fitting regular soft contact lenses, but we should look for a smaller or even no movement in fitting soft OK lenses. Appropriate lens size is important for centration, which is better 1 to 1.5 millimeter beyond the limbus on each side. So no worry about tear circulation for little movement of the lens. Soft-OK lens has a tear channel that supply abundant tear for lubrication. For outstanding corneas, 12.4 millimeter or bigger, the 14.4 millimeter soft-OK lenses will be too small and become unstable. So we have to check the HVID that should be smaller than 12.4. So when we insert the soft-OK lenses, it is better to apply a drop of saline or tear in the lens bore to prevent from air trapping. However, sometimes that if you do not apply the saline or thin tear in the lens bore, it is still fine. So if you insert with a drop of saline, the insertion has to be head down posture and insert the lens upward to keep the solution in the bore. If there is significant amount of air trapping, the wearer may feel stinging or discomfort with slightly distorted vision. So rubbing gently on the eyelids may expel the air. If the air persists, the user may need to remove and insert properly with a drop of saline in the bowl. That is the brochure. Okay, for the soft lenses, we also have a very interesting applications for improvement of binocular dysfunction. We found that the peripheral defocus, especially the horizontal peripheral defocus, may improve the exophoria or convergence insufficiency dramatically. So we now are doing some research on this because we don't think that the some exophoria or the convergence insufficiency is due to the muscle or neurology, but it could be caused by the eyeball shape that has a poor peripheral fusion. So we can correct it with the peripheral defocus lenses. So that is a case that we illustrate is a exophoria case, and then after surgery becomes esotropia. And after we apply the sub-ocular lenses, the eye straightened dramatically without any training. Okay, thank you.
Thank you, Dr. Arthur, for the wonderful presentation and insight. So I would request the expert panel if they have any questions for the speakers. Dr. Meena, Dr. Ashi, Dr. Charada ma'am, any questions?
Yeah, maybe I will ask for this is both of them have presented something totally new from what we practice, and what we practice is flow myopia up to -6 with 0.5 steps, and astigmatism probably maximum 1.75. So this is our experience with myopia treatment. With regard to the GOV lens, he mentioned that it could correct high myopes also. But we also see that the daytime regression after the lens is removed is much faster when treating high myopes. So I wanted his comments on how these patients, we know in low myopes, the regression of the number is less towards the end of the day. But for high myopes, I was just wondering how these patients are compared to the patients with -6.
Do you mean that how they keep the vision all day?
The whole day. These are nighttime ortho lenses, as I understand, or is it day wear? I mean, both exist. So the common thing is nighttime wear of ortho case. So if you're correcting -10, how after removal of the lens, the patients up to what time they enjoy the vision?
Yeah, actually we have practiced the high myopic molding for over 20 years, and we can achieve 20/20 or nearly 20/20 vision whole day without sleeping too long. Actually, with a -8, -7, -8, they can sleep only 6 hours every day, and then they keep whole day clear. So we are different that we push the tissue from centrally outward, also peripheral inward. And that is why we can build up a very high peripheral stiffness ring. The stiff ring will keep the vision clear for whole day. But however, that for molding the high myop, the skill has to be very precise. So we do not want the lens to move too much. And then we also do not want the lens to decenter. So all the skills that we talk about, the size control, and also the K-code interpretation, and also the fluorescein interpretation, all very important. So we do not want to start with the high myop and then interfere in practicing the also K, because that you have to start with the lower myopia and then learn all the skills and then merge into the high myop cases. And also we have to check, we will teach about the later, we will teach about the trouble-free fitting and also the how to design the quadrant lenses. That means that the cornea is not always spherical or aspheric. They can be very irregular at periphery. So we all regard the irregular cornea at center. That is important. However, for also K, the irregularity at periphery is most important for fitting because we want to fit the lenses properly at periphery so that we can push the tissue regularly at center. So we will talk about the quadrant lenses in the third or fourth talk. So that is the most important portion. And so that we should have a very appropriate topo map. So the topo machine is very important. Some topo machine are not good, no good at all. So we need a proper topo machine, and then I will suggest that the best machine is Medmont, and the second is Oculus. So if you have the one of the two machines, then it will be very easy to practice GOV lenses.
Because there is a mid-peripheral tightness in this high myopes. Do you get any nipple-like cones in the center? Do you get that nipple effect anytime?
Pardon me?
Do you get the central nipple-like elevation in these orthokeratology lenses? Have you ever seen in some of these lenses which are customized, like for the Paragon CRT lenses, some of them develop a nipple-like excrescence in the center, and these cause glare. So any effect of glare in any of your lenses? No. Glare at the end of the day.
What you're talking
Because
about
of the irregularity in the cornea that it causes, does any glare come into these patients?
You mean irregularity at center?
Irregularity, or you're saying the overall surface of the lens is irregular, especially in the periphery?
I don't quite understand.
I
Chris?
think
the question is regarding complication.
So I want to ask regarding refitting. In a child with orthokeratology, who's using the lenses regularly, and compliance is very good, but visual acuity declines over, say, 1 year or so. So what would be the finding which would tell you to sort of refit or just modify the base curves?
So to refit the lenses, all you'll do is order, if the lens is fitted perfectly and your corneal topography is perfect and your centration is all good, but you need to get maybe a minus 0.50 higher power, you just order the lens exactly the same, but with a higher power. And for the previous question, I think what you were referring to is perhaps like what we would call a central island, which is what we would address when we talk about troubleshooting in the fourth lecture. But troubleshooting is generally due to the fact that your lens, you don't have an optimum bullseye pattern. So if the lens is a little bit too steep, if your K code is a little bit too steep, or your lens is a little bit too large, you will get the central island in the center of that treatment zone. I hope that, does that answer the question?
Yes, sometimes the central island will be in a form of multi-shaped astigmatism.
Okay.
And sometimes it will form just a protruded point.
Yes, that's what
at
I
center.
meant. Yes,
Yeah,
maybe that's
sometimes.
what I just, since I don't practice this regularly, maybe I didn't.
Yeah, but
see.
we have to be very sure that it is the central island, because sometimes some cornea abrasion at center, it will still forms a central island like image in the topography. So if it is a central island formed with a tight fit lens, then the only way is to loosen it, to loosen the fit, and then the lens will bear on the center more properly to push down the central island.
So I had a question, since most of the soft OK lenses would be more appropriate for children. Apparently, since we're mostly using ortho K now for myopia progression. So are the complication rate any different, or are the different kind of complications that you see with the soft OK lenses
You mean
in the pediatric population?
the complication? Just
That's
like
right.
the cornea ulcer or something?
Well, so what we see are the epithelial irregularities, so those kind of things, or anything else that you would like the list
Oh, the soft OK lenses?
Also, like I would like to
to,
point
yeah,
out
for
that
soft OK
we
lenses.
are, yeah, I have a point that if you're changing the epithelium for so long a time, is there any long-term complications on the biomechanical changes as the child grows up and the biomechanics goes down, so that we are not able to do a refractive surgery in the future, or it leads to low
No.
corneal hysteresis or
Okay.
something?
Okay, I understand. So for the soft lenses or contact lenses, the previous thought is that it will change the will damage the endothelium and to cause the irregularity. However, with the high decay material that we do with the silicone hydrogel, the condition is much better. And then also we have a tear channel underneath, so that the lubrication is much better. So previously, we always worry about the neovascularization at periphery. However, we thought it is due to oxygen insufficiency, but most of the case, it is because of the lubrication. If the poor lubrication of the lens, then it will form neovascularization even with the high decay material. So
Right.
we create the lens with a tear channel underneath. We will solve the peripheral lubrication problems. So we have many years experience with the soft OK lenses, even with the HEMA lens. That does not cause any cornea problems for several years, for maybe 10 years. So I think it is even better. Now we use the silicone hydrogel with the tear channel underneath, and that is even better.
Okay, thank you. Thank you, Dr.
Okay.
Arthur.
I wanted to add
Thank you,
that
Dr. Chris.
microbial keratitis can be very rare
It is,
complication,
yeah.
and it is a little bit related to the lens fitting as well. So if there's a poor tear exchange or exposure to tap water. These two have been found to be the risk factors, and I've seen cases related to these. But it's all said and done, the data is very 5 in 10,000. It's very rare complication.
Right. Thank you. Thank you, Dr. Charita, Dr. Meena, and Dr. Ashi, ma'am, for joining us for this evening and sharing your expert points. Big thank you to Dr. Arthur and Dr. Chris for taking out the time. They will be joining us for subsequent classes also.
Yes.
And over to Dr. Praful to conclude the session.
Yeah, Ritika, thank you for nicely conducting the session, and thank you to the panelists, and thank you, Dr. Chris and Arthur. And you will be with us subsequently for 3-4 classes. And in India, the ortho-K is still not that commonly used. I hope after this series of lecture, our optometrists as well as ophthalmologists, they also start to know the pros and cons of using such lenses, and it may improve they may include in their practice also. And along with that, thank you to those 700 odd delegates who joined us for this webinar. And our contactless programs are always a huge hit. A lot of people join. At one point, almost 400 people are watching it live. So thank you so much, all the delegates, for making this a hugely successful course. And we will try to do as good as we can in subsequent lectures. And to my panelists, I know the topic was little awkward to most of us, but thank you so much. The discussion that you carried forward was excellent, and I hope DOS keeps on troubling you in our subsequent webinars also.
Yeah.
With
thank
this,
you.
let's conclude
Thank you,
here.
Praful, and thank you for inviting us. It was wonderful. The excellent talks and both the speakers were great. Thank you.
Thank you.
Thank you, ma'am.
Thank you. We learned a lot.
Good night, all.
Good
Good
night.
night,
very
everybody.
much. Good night.
Good night.